Welcome everyone to the OCO webinar series. I'm Stacey Chung, Engagement Coordinator at the Ontario Caregiver Organization. I am your moderator today. Today we will explore sleep, insomnia, and the role of sleeping pills and non-pharmaceutical approaches to achieve a good night's sleep. Dr. Gardner will delve into issues commonly faced by caregivers that include difficulties getting to sleep, staying asleep, sleeping pill risks, effective alternatives, and much more. The quality of sleep that we get is critical for our well-being. Research does show that when caregivers take better care of themselves, their care recipient benefits too. So how can we improve the quality of our sleep? We hope this webinar can help. I am pleased to introduce today's speaker. Welcome, Dr. David Gardner. David has been teaching medical students, physicians, pharmacists, and others at Dalhousie for many years. Lately, he has been focused on research to build improvements to the healthcare profession, specifically in the area of insomnia. He aims to help people reduce the overuse of sleeping pills and increase people's use of CBTI. You may not be familiar with this term, but by the end of the webinar, its meaning should be clear. Welcome, Dr. David Gardner.
Well, thank you very much. I just want to give you a little bit of background before we get going. So I'm a professor, as it says on the title slide, it says I'm a professor with the Department of Psychiatry as well as with the College of Pharmacy at Dalhousie University, so here in Halifax, Nova Scotia. A long time ago, we moved from Scotland as I was a young child to Kingston, Ontario, so I did most of my growing up in Ontario. I ended up going to university in Toronto and lived and worked in Toronto for quite a few years before going back to school and doing some graduate work out west, and then taking a job that's got a mix of things. So in my day-to-day, there really isn't a regular thing. It's more year to year, there's some repetition, but it does involve clinical practice as well as a fair amount of research and teaching that Stacey reviewed with you. I do want to make it really clear that I would really like to have your questions at the end of this. So as I'm going through the slides and discussing things, please feel free to jot down your questions, write them in the chat. Stacey and Susan will be reviewing them and will be hopefully supporting a good share of ideas based on the questions that you put forward. So with that quick background, I'll just jump right into things. So now I'll make sure I can move my slides. There we go. So I'm just going to quickly say a couple of things about insomnia, but I need your help with that. So if you don't have your chat boxes open, please open them up because I'm going to ask you a few questions and I'd love to see your answers come through in the chat box about insomnia. And then we'll talk about sleeping pills relatively briefly, but get through some important things about the sleeping pills. And then introduce to you, as Stacey was mentioning, something called CBTI, and we'll hopefully go over that in enough detail that you'll feel well introduced to it and want to look into it a little bit more on your own. Okay, and moving right along. First question, and this is truly a interactive question, so get your cursors over to the chat box. Which is not part of the diagnosis for insomnia? Problems falling asleep, staying asleep, or waking too early, number one. Number two is feeling distressed the next day about not being able to sleep. Number three is having the opportunity to sleep, but having problems with number one and two. Or number four, experiencing the need to move your legs as you try to fall asleep. Which one of those is not part of the diagnosis for insomnia? I see a few people are saying number four, and that would be correct. Experiencing the need to move your legs as you try to fall asleep is a problem that many people live with, known as restless leg syndrome, and it's a cause of insomnia, but it's not a required component for the definition. So numbers 1, 2, and 3 are part of the diagnostic criteria. You have to have difficulties with either falling asleep or staying asleep or waking up too early. So any one of those three or all of those three. Feeling frustrated and distressed the next day, feeling like your functioning is impaired the next day and just feeling distressed about that is part of the diagnosis. And you have to have the opportunity to sleep. Obviously, if you're a shift worker working overnight, you can't complain about it being insomnia because you haven't actually had the opportunity to sleep. So number 4 was the correct answer. If you have insomnia for 3 nights or more in a given week, then you will fall into one of 2 classes. Either short-term insomnia, if you're experiencing that for less than 3 months, or if you're experiencing problems with sleep for 3 or more nights a week for longer than 3 months, it can be referred to as chronic insomnia, or what is become a new term in the last few years is insomnia disorder. So you may see this term being used now, a new term by the American Psychiatric Association from 2013 is insomnia disorder, but it's otherwise referred to as chronic insomnia. All right, so my next quiz for you is really just a true or false, but in this case, it's truth or myth kind of question about insomnia, which are true and which are false, or which is a myth. Number 1, I'm supposed to get 8 hours of sleep per night. What do you think? Is that truth or a myth? And that's a myth. So the right amount of sleep really depends on you. It varies from person to person. Some people do quite well the next day with 6 hours, 7 hours, 7.5 hours. Some people do better when they have 9 hours of sleep. So it's highly variable, and it also varies within the person. So you may find that on one day you've had 7 hours of sleep and done just fine, and on another day you've had 7 hours of sleep and you feel very poorly rested. So this 8 hours of sleep a night, it's come out of somewhere. Nobody really knows where it's come from, but it's not an absolute truth. And we really shouldn't be living by this 8-hour number. We should be thinking about how we're actually feeling and if it's adequate for us on any given day. I shouldn't be waking up in the middle of the night. Is that true, or is that a myth? Yeah, so I see a lot of people see that as a myth as well. You know, it's normal, it's not welcomed, but as we get older, it's normal to wake up in the middle of the night, and it's normal as we get older to wake up more than once or for a prolonged period of time. And if we go way back to the Dark Ages, there's actually some evidence that this has been something that's been well recognized, especially prior to electricity, when people would go to sleep when the sun went down. And for people in northern latitudes far away from the equator, that would be for a long time in wintertime. So you'd sleep for a while, you'd wake up, you would do something for an hour to an hour and a half, and then you would have your second sleep in the middle of the night. I know I have chronic insomnia because I can't sleep without my sleeping pills. Does that tell you that you have chronic insomnia whenever you try to stop your sleeping pills? The sleep problem, the insomnia comes back? Boy, everybody thinks everything I'm going to say is a myth. And that is a myth. Stopping sleeping pills very often is the cause of the return of insomnia. So in my little world, we actually refer to that as rebound insomnia, or probably more accurately, withdrawal syndrome phenomena. So if you've taken a sleeping pill for several weeks, months, or even years, and you stop that sleeping pill over a few days, it's very common to have a sleep problem and some other symptoms of medication withdrawal. And sometimes I say that one of the most common causes of sleep problems in people who take sleeping pills is the stopping of the sleeping pills themselves. It's not an inherent ongoing problem with insomnia per se. And the last one here, once an insomniac, always an insomniac. And I think I'm going to predict that you're going to say this is a myth. or a myth for sure, as somebody wrote. And I would agree with you that it is a myth. So there's a way to think about insomnia by breaking it down into its factors or its causes. And I want you to think about it as three different categories. The first one is the predisposing factors. So those predisposing factors are things that we can't really do anything about, like how old we are. The second one is the precipitating factors, the ones that trigger or bring on the insomnia. So, you know, caffeine late at night, that could be the trigger of that night's insomnia. But it could also be something like bad news, a significant stressor in your life, the loss of a loved one, for example, or learning that you've just lost your job, something along those lines can trigger insomnia. So we have predisposing factors, we have precipitating factors, but really importantly is the perpetuating factors, or those that promote insomnia to continue on. So those perpetuating factors are things like napping. If you feel like you can't sleep at night and you don't sleep well, you often make up for it by napping the next day. And other people will go to bed very early with the hope that the earlier they go to bed, they'll actually be able to get a better sleep. So going to bed too early or napping can be what we call a maladaptive adjustment to your sleep problem, only making it worse. Another way that the insomnia can be perpetuated is that you get frustrated, and over time you're conditioned to go to bed and be frustrated. So kind of a classical conditioning phenomenon. The second your head hits the pillow, you start worrying about not being able to sleep, and that only makes your brain more aroused, which makes it next to impossible to fall asleep. So that obviously would perpetuate insomnia. So we're going to talk about a way to address those types of factors, all of the factors, not just one or two categories. I like this very simple summary because I think it's actually dead accurate. What is insomnia? Well, insomnia is feeling tired in the morning, dying for a rest in the afternoon, but by the time it comes to going to bed and trying to sleep at night, you can't. I think that's a good capture of what insomnia is. If you have the impression that the rates of insomnia go up in older adults or as we get older, then you would be right. Data from studies where researchers actually go to the homes of thousands and thousands of people and interview them, no matter who they are, just randomly picked individuals, has found that people who identify having problems with insomnia, it's more likely as we get older. So based on this study that I've identified here, a nice old, really well done epidemiological study, people who were older answered, yes, I feel bothered a lot by trouble falling asleep or staying asleep anytime in the past year at a rate of 25% if they were 65 and older, compared to just 14% if they were 18 to 34 years of age. So there's definitely truth to the fact that we experience difficulties with sleeping as we get older. When I was in school, this is going back a long ways to my time in pharmacy school at the University of Toronto, we learned about how to manage insomnia. And we talk about it in two different ways, the pharmacological way and the non-pharmacological way. And so I'm going to start off by focusing on the pharmacological way and thinking about sleeping pills. But really the pharmacological way is a bit broader than the pills that you get at a pharmacy. It's any pharmacological intervention. So we sometimes talk about medications and substances. Cannabis has certainly increased in terms of its use for helping people sleep. Alcohol has been something that's been used for eons for its effect on sleep. By saying cannabis and alcohol, I'm actually not recommending them. There are issues with them, but I'm going to start off by focusing on the most commonly used approach to managing sleep when you go to the doctor, which is a certain type of sleeping pill. So we're going to look at what people use, how effective they are, and how safe they are. So on the list here, I'm going to make you little mini pharmacologists. On the list here are the most commonly used class of medications called the benzodiazepine receptor agonist. Some people call them the benzos and Z drugs. So I might switch back and forth and say benzos and Z drugs, but you can see why some of them are called Z drugs because they all start with the letter Z, or it's a dominant part of their name up top. And then the benzodiazepines in the second, third, and fourth rows are those that have been used really very commonly since the 1960s. The one on there that I would guess most, if not all of you have heard of, is diazepam, known by its brand name as Valium. So the most commonly used sleeping pill on that list is the very first one listed. It's the little blue pill shown in the top right corner there, known as zopiclone or Imavane, and I'll talk about that and a couple of examples coming up. But Ativan is also very common. The number 1 and number 2 sedatives or sleeping pills or hypnotics are lorazepam or Ativan and zopiclone and Imavane. But all of these on this page really do the same thing. When they act in the brain, they enhance the effect of one of our brain's chemicals or neurotransmitters called GABA. GABA is something that actually helps us relax and sleep. So the more active GABA is, the more able we are to fall asleep. And all of these medications work the same way by enhancing the ability for GABA to do its thing. There are other medications that work quite differently that are also used for helping people sleep. And none of these have been approved by Health Canada for the purpose of treating insomnia. Trazodone is an antidepressant, originally marketed under the brand name Deseril. It's now available in a whole variety of generic formulations, but it probably makes up, for every 10 sleeping pill prescriptions, it's probably 1 or 2 of those 10 sleeping pill prescriptions. The other 2 antidepressants listed here, amitriptyline and doxepin, are very sedating. They're used for a few different things. Amitriptyline is used for chronic pain, neuropathic types of chronic pain. It is an antidepressant, but these days it's really not used any longer for the treatment of depression. At low doses, it's very antihistaminic, and antihistamines that get into our brain make us tired. So amitriptyline's antihistaminic effects make us tired. Moving down one row to quetiapine or Seroquel, it's classified as an antipsychotic, but it too at low doses is antihistaminic. So we've got sort of 2 rows of drugs that were never intended to be used as sleeping pills, but because of one of their pharmacological actions, this antihistaminic effect, they're sedating. And at low doses, people have been using them quite frequently for the treatment of sleep problems. So it makes a lot of sense when we go to the 3rd row and look at the sedating antihistamines that you can buy over the counter in a pharmacy without talking to the pharmacist, without talking to your doctor, and using it for helping you sleep. So many people have experienced taking Benadryl, which is diphenhydramine, or other antihistamines for itchiness or allergies and feeling quite sedated because of those. And other people will actually buy formulations like Nitol or other sedating antihistamine formulations you can get at the pharmacy because of that side effect to benefit their sleep. These 2 are not approved by Health Canada for their use in insomnia, and they tend to cause a variety of other effects and not work for many days after they've been used on a nightly basis. And then the last row is melatonin. Many people, I'm sure, are familiar with melatonin. Our brain makes melatonin. Every day around sunset, we release melatonin, and that signals a shift in what the brain does to help it get ready for sleep. L-tryptophan is a chemical that's available through food, a variety of different foods that we take. Large doses of it make us feel a little sedated. And then there are some herbal products like valerian root that are also associated with feeling sedated or relaxed. So my next question for you is, which of the sleeping pills that I've mentioned, and I'll just go back for a second, show you that list. And I should mention that the PR and the C are sort of the Health Canada classifications. The C means controlled drugs, so it's in the Controlled Drugs and Substances Act. And drugs that are put in the Controlled Drugs and Substances Act are done so because there is sort of a legal or a police concern about something we call diversion, where the drugs are diverted from the legitimate or ethical use market to the black market. And really all of them on that page should be classified in many parts of the world. They're all classified as controlled drugs. For these drugs here, so which of those has been received approval by Health Canada for the long-term or the chronic use of the treatment of insomnia? Any guesses? See one guess, melatonin. It's one of my trick questions. No sleeping pill has been approved for use extending past 4 weeks. So all of the sleeping pills ever considered by Health Canada, regulated and approved and currently on the market, have details in the product monograph, as we call it, that say to be used for 2 weeks or less, and for 1 or 2 for 4 weeks at an absolute maximum. So that's not exactly how they're used. They are very commonly used for much longer than that, and there's a whole bunch of reasons for that. And I won't discuss those, but I will discuss quickly the evidence of how effective they are. And please feel free to throw your answer as a number to the following 2 questions in the chat. How much faster do you fall asleep with sleeping pills, regular sleeping pills that I've just reviewed, when taken on a regular basis? For example, 2 weeks, 4 weeks, 6 weeks, when compared to placebo. So how much faster do you fall asleep? And let's say for somebody with insomnia, on average, it takes them 60 minutes to fall asleep. The pills are going to help with that, but placebo also reduces that time as well. The answer is 7 minutes. When compared in properly designed studies where you don't know if you're taking a sleeping pill or a placebo pill, the difference is just 7 minutes faster to fall asleep. And how much longer do you sleep with sleeping pills taken on a regular basis compared to placebo? And the answer is 15 minutes. So these medications are used extensively across Canada and around the world. And I don't think people appreciate that that is the extent of their advantage. So let's move on to talking about how safe these medications are. And I'm going to just go through the main concerns that we have with these medications. The sleeping pills, the benzodiazepines are kind of the focus here, but most of the information applies to all medications that are sedating. So one of them is when mixing benzodiazepines and Z drugs with other medications. We have all heard over the last several years about concerns about the opioid crisis. The rate of use of opioids has dramatically increased in the last 20 years. When combined with other medications that cause brain activity to slow, there is an increased risk of death from overdose of these medications. And the data shows that in the last 20 years, the risk for overdose deaths is 8 times higher when looking at people who have combined benzodiazepines and opioids. But the same is true for other combinations. So it's not just opioids, but it's other medications that are also sedating, and there's quite a few different classes of medications that benzodiazepines will add to the risks due to the cognitive impairment associated with these other medications. And I should add substances like cannabis, as well as alcohol. They increase the risk for injurious falls by 60%. And in particular, most of the research has been on injuries causing bone fractures or broken bones. So across all the different bones, the risk increases 66%. But hip fractures are of special concern because of the high rate of mortality following a hip fracture, which is somewhere around 40 to 50%. It's a very high rate of mortality within the first month to 2 months after a hip fracture. And the use of benzodiazepines increases that risk of hip fracture, somewhere, depending on which study you're looking at, between 50 and 90%. What's not well recognized, so this would be information that I share with, for example, family doctors and psychiatrists and other prescribers of the benzodiazepines, is the increased risk of pneumonia and flu-related deaths. And in the age of COVID-19, this couldn't be more particularly of a concern. What's been identified is that the benzodiazepines actually they don't just affect brain chemistry, but they also have an effect on immunity. And they seem to slow the reaction of our white blood cells to reduce the risk of a secondary bacterial infection following a viral infection. So very often we have a flu, which is a virus. Some people are at higher risk of having a bacterial infection following that viral infection. And it seems that if you're taking a benzodiazepine at the time that you develop the flu, then you have a higher risk of developing pneumonia, bacterial pneumonia, and you have a much higher risk of dying from that complication of the flu. One of the biggest concerns about the benzodiazepines is the risk for falls. And it's not just that we're concerned about having an injury from falling, but it's what's the effect on the individual's sense of confidence and outgoingness and activity, both mental and physical activity, when they feel a little wobbly because of the adverse effects of the benzodiazepines. I probably won't surprise you when they do studies with people taking benzodiazepines, when they close their eyes, they tend to sway more. This is called the Romberg test. Maybe some of you have had some experience when you visit your doctor and your doctor says, please close your eyes, and they just look at you. And they're really looking for how well balanced you are with your eyes closed. And it shows that your balance is decreased when you're taking benzodiazepines. So it's not surprising that there's more people who feel less stable on their feet, who have more experiences with stumbling or having a fall that didn't cause them to need to visit their doctor or go to the emergency room. But because of these experiences, they start to withdraw and isolate themselves. And there's some interesting research to support that this happens. And another major concern, or area of research that I'm working on with a few others, is the effect of sleeping pills on driving. And one of the standout concerns is our #1 sleeping pill in Canada, which is zopiclone or Imavane. If you take zopiclone at night and then you drive 10 or 11 hours later, driving studies have shown, so people who have taken the sleeping pill, slept the night before, got up and did a driving study the next day, show that the level of impairment in your driving ability is the same as if you had 2, maybe 3 shots of vodka, waited a half an hour, and then went driving, which is a blood alcohol concentration of around 0.05 to 0.10 across the different studies that I have looked at. And here I've shown a BAC of 0.08. So imagine if you're somebody who takes a sleeping pill and then the next day, maybe goes over to your daughter's house to take care of her children in the morning because you are the caregiver for the children during the day while your daughter goes off to work. Or you have to do something the next day for your job, and your job requires you to operate some sort of machinery or a drive or whatever it is. And as somebody has said, that they always feel groggy the morning after. Zopiclone, for many people, they recognize it, but not everybody recognizes the impairing effect the next day The studies are up to 11 hours demonstrating such an important level of impairment. What's really been well known ever since we've been using these medications is how they impair memory. When you take a sleeping pill, it's harder to remember what happens after you take it. That's called retrograde amnesia. They cause cognitive impairment, meaning you're not as sharp, you won't remember, you won't be able to respond as quickly to new information, which increases risk for car accidents and so forth. And then there's also the concern of dementia itself. There are studies that show a correlation with the use of these medications and cognitive decline or dementia. Whether it's causative or not remains to be determined, but we do know that there at least is a correlation. And the last concern that I'll share with you is the development of dependence on the medication, a physical dependence, and for some people, a psychological dependence. And this is manifested in what we call the sleeping pill vicious cycle. You have insomnia at the top, and you start to go around the clock to say 1 o'clock or so, and you start taking a sleeping pill, and it makes you groggy and it helps out. But after a while, the sleeping pill starts to lose its effect and it's not as beneficial. So as you get around to 7 or 8 o'clock there, you'll see that you start taking 2 sleeping pills, you increase your dose. And they have a bit more of an effect, but still not as good as at the very start. So with chronic use, you get less and less of benefit over time of the sleeping pill. And at one point, either you run out or you don't get it prescribed anymore by your doctor, or for whatever reason, you stop using the sleeping pill. And then you go through the withdrawal syndrome. And the #1 symptom of the withdrawal syndrome on the right there is insomnia. But it can be a whole variety of other signs and symptoms that's experienced: anxiety, irritability, headache, sweating, pounding heart, this heightened sensitivity to noise. And you know what takes all of that away? Taking another sleeping pill. Within a half an hour of taking another sleeping pill, that withdrawal syndrome is gone. And so you can imagine how that is such a strong reinforcing effect that makes you think you need that sleeping pill, or makes you realize I am now dependent on that sleeping pill, and how do I get off of it? So that brings us to a term that's become very common in my world, maybe not yours, which is the term Dprescribing. Many people know all about prescribing, how to start medications, but do people know how to safely and appropriately stop medications when it's the right thing to do? So I'm going to ask you a question. This is Peggy, and she's a 77-year-old woman who's been treated with a benzodiazepine or Z drug for 10 years. And she takes other medications too for some other health issues. What do you think the probability is that she would successfully, spontaneously stop taking her benzodiazepine, her sleeping pill, within the next 6 months if she's already been taking it for 10 years? 0%, 5%, 25%, 50%, 90%. Yeah, you know, I see answers between 0 and 5%. And you know, what would promote Peggy to think, hey, it's a good idea for me to stop taking these? Unless her doctor or her pharmacist brings up some of the issues, which very often she's not interested in them talking about, and they don't think she's interested. And so the use of the medication just kind of goes along unchecked. What if we gave her these 2 brochures? One that's called "You May Be at Risk If You're Taking One of the Following Sedative Hypnotics," which is all the benzodiazepines and Z drugs, and another brochure that's called "How to Get a Good Night's Sleep Without Medication." Do you think that print information, just giving her a couple of booklets, could help her? Well, that's been studied. And it's been studied by a group of investigators in Montreal, a really well-known study these days by those in the field of insomnia management. The study included people who were 75 years of age. They were taking 10 meds per day. And they had been taking their benzodiazepine for about 10 years. The insomnia, the reason for taking it was for insomnia or anxiety, and people who went into the study were randomly allocated to get those booklets or to wait till the end of the study and then get the booklets. So they got this one first, and then a week or so later, they were offered to receive that one, and almost everybody said, sure, I'll take it. And the other group, the control group, didn't get any of this until the study was over. What was found is if you send these booklets, 27% of people kind of like Peggy stopped their sleeping pills over the next 6 months. And for those kind of like Peggy who just went along as normal, who didn't get the booklets, 4.5%. So for those of you who said 5%, you were right in line with what was found in this study. So just receiving these booklets seemed to have a substantial effect on people's comfort that caused what's called cognitive dissonance. So I just want to show you what's in the booklet that they first received. The You May Be at Risk booklet had a few photos that people could identify with, had a quiz, had some answers to those quiz questions, told people, you know, a few things that would maybe make them a bit concerned about sleeping pills, had them reflect via a few ask yourself questions, listed alternatives of how to get a good night's sleep, gave a very positive story of a woman who was able to successfully stop her long-term use of sleeping pills, and then really supported helping them learn how you can gradually, safely, cautiously stop your sleeping pill over 18 weeks. Many of people went to their doctors and pharmacists to get guidance and support in doing that. Those who did do that were even more successful. But when you take all the people together who received this booklet and the other one, it was close to 30%. So there's a link there, and I think it's already in the chat box. For those of you who are interested in getting a copy, because there's the Canadian Dprescribing Network provides this booklet for free. If you want printed copies, you can just get directly in touch with them and they'll mail it to you. Or if you want to print off a copy from your own computer and printer, you can do the same. So let's move on now to what's considered to be the first line therapy of insomnia. Although we currently use sleeping pills as if they're the first line therapy, they are actually not the first line therapy. So the American College of Physicians recommends cognitive behavioral therapy for insomnia. It's a bit of a mouthful, so we call it CBTI, for the treatment of chronic insomnia disorder. The European Sleep Research Group also makes the exact same recommendation and makes it clear that pharmacological interventions should be offered only when CBTI is not effective or not available. And then a guideline that's a Canadian guideline that I was involved with the development of, we published it this year, and it's available online at ccsmh.ca. If you're interested in the guideline itself, it's about the use of these sleeping pills, the benzodiazepines and Z drugs, and how to avoid becoming dependent on them if you're an older adult. Those guidelines state the exact same as the previous two. First line treatment is CBTI, and to avoid using the sleeping pills unless CBTI fails. So what is CBTI? And this is what I'm hoping that I'll get questions about, as well as give you a good introduction to before we're all finished today. So as I mentioned, it's the best treatment for insomnia as recommended by groups internationally. There's different formats now. 20 years ago, you could get CBTI by visiting a therapist and seeing them in their office. But now there's self-help approaches that are effective in book form or as an app or web-based services. And I'll show you some of those. It usually runs for about 4 to 8 weeks, but within 2 weeks, there's improvements in sleep. And unlike sleeping pills, when you're done with this approach, it actually has been shown to prevent insomnia from returning because you've learned how to manage your sleep such that insomnia can't return. There's 5 components to CBTI. Most people who use CBTI do not need or use all 5 components for them to get their sleep back. And obviously, it's much less risky than taking sleeping pills. So we'll just go into some of these in a little bit more detail. Some of you may be familiar with the advice that if you're not asleep after 20 minutes in your bed, you should leave the bedroom. So I'll just add to that. You should have a set bedtime or a set time where you plan to go to your bedroom to go to sleep. And you should try to do that on a regular basis. But if you're not sleepy, don't go to bed. Don't even go into your bedroom. Maybe get ready for bed, do all the things that you do to get ready for bed. But once you realize, I'm not sleepy, go out of the bedroom and do something really boring. Who here has read, let's see, what would be a really boring book that would help you fall asleep? Not online, you can't read it on your phone. Moby Dick, would that be, anybody read Moby Dick and found that it kept you up all night? Was it a real page turner? Don't find a real page turner, find something that's going to be unimpressive, relatively speaking. When you're tired, then you go to bed, turn the lights off right away. If you find you're not sleeping, get back out of bed and leave the room. So that's what they mean by control. You're in control, only go back to bed when you're sleepy, and just keep recycling that until you fall asleep. This is really important for people who have a really negative association between sleep and their bedroom. They're trying to fix this. You could read the dictionary. I think that's a great idea. So for recommendations, visit our website, which is called mysleepwell.ca, and you can click your way around. I really invite you to get to know that website, particularly about CBTI. But we do have some tools within there to support your use of this approach that we call control or stimulus control. There's something also called sleep drive, and this is really important for people who have chronic insomnia. It's a very effective intervention. You start off by filling out a sleep diary for 7 or 14 days to get a good idea of what your sleep numbers are. Then you identify what your average night of sleep is. How many hours of sleep do you get on average in total? And that's the amount of time that you start off with in bed. So that starts your sleep prescription. So it's shown here on the right that if you're getting 6 hours of sleep in total on average based on your sleep diary for the last 2 weeks, then you should only be in bed for 6 hours. Go to bed later than normal and rise at the time that you want to be getting up anyway. So if you pick 6:30, you backtrack 6 hours and you start at 12:30. One of the things that you do with a sleep diary is you measure your sleep efficiency. It's a calculation of the time you're sleeping compared to the time in bed. Once your sleep efficiency gets above 85%, you get to have more time in bed. So this really helps to consolidate your sleep and get rid of your negative associations of being in bed and being frustrated and awake and worrying and so forth. So it takes 2 to 3 weeks for you to start to get more and more time in bed. The other components come along usually after those that I've gone through. Sleep hygiene does come in a little bit earlier, but often it's one that people have already tried everything to try and improve their sleep. So often sleep hygiene is not the most emphasized component, if you will, of CBTI. Relaxation techniques are really important for some people, and for others, it's not that important. And cognitive therapy to help you rethink your way into sleep, to help your brain get ready for sleep is also very important for some people, but not that important for others. If you want to learn more about them, we do recommend different tools and different, what I call programs for CBTI, and a book can be a program at MySleepWell. So the real purpose of mysleepwell.ca is to help people get access to CBTI. So this is an average treatment course of CBTI. You start off the first 7 days at the top with your sleep diary. Then you learn about sleep hygiene and control, moving into sleep drive techniques in the 3rd week, and then a bit more emphasis on relaxation and management of your thoughts in the 4th week, and so on. And you maintain those after you've learned about them. So they're not all brought in at the same time. There's lots of evidence. There's actually an unbelievable amount of supportive evidence of the effectiveness of CBTI whether it's in people who are older or younger, whether they have other health concerns, including depression or other mental health concerns, or physical health conditions, whether it be pain-related, or whether you have had cancer or have cancer, fibromyalgia. I haven't listed them all here, but just to give you an idea of the range. PTSD, there's a long list. And the studies have been done whether you received the CBTI from a therapist, a book, an app, or online. So how do you get access to CBTI? And that is what our website is helping people do. So go to Sleep Well, and you see up top in the menu information about insomnia, information about sleeping pills, CBTI, and the most important link, Sleep Well recommends. So what Sleep Well recommends are books that basically provide you with a self-led program in CBTI. Sink into Sleep is the one that I've recommended the most. It's written by a psychologist at Queen's University. She's coming out with the second edition of that at the end of November, but the first edition is really simple to use, and I think it's very effective. The others, for example, the Insomnia workbook focused on slightly different things. If you want more details, they're available at mysleepwell.ca if you want to read the details about these different books. But if you're hesitant and you're unsure, just start off with Sink into Sleep. I don't think you'll go wrong with its use. If you're more into apps, there's a relatively inexpensive app with a terrible name called Go to Sleep. It's from the Cleveland Clinic Wellness. It's about $40, but they're very good at contacting you. You use the app, you report your sleep, and they provide you with all of the components as you go along and you can do it through your computer as well. It doesn't have to be on the phone, but as you go through your CBTI program, all of the components. And if you really want to see a therapist, there's a group based out of Montreal, but it's kind of therapists from all across the country. It is $100 a session, and they recommend 5 sessions. It may be that your health insurance does cover it, so you might want to look into that. But you get a half an hour with a therapist on your phone, live, just kind of like what we're doing here, but more like visual interaction with your therapist. So a chatting session with them, if you will. So I'm just going to finish off by taking us a little bit further back. This is from a book I found on my grandmother's shelf a long time ago. And in reading it now, I realize what I've just talked to you about now is something that's been known for a very, very long time. When in bed, it's best not to anticipate a bad night or think deliberately about getting off to sleep. So that right there is part of cognitive therapy. The sufferer should concern himself only with making himself thoroughly comfortable, sleep hygiene, and should try to stop thinking, cognitive therapy. A word of warning, it is most inadvisable for anyone to have recourse to sleep-producing medicines, except under the personal direction of the doctor. Such drugs are dangerous when wrongly used and are seldom necessary if the natural means to sleep are fully tried. That is unbelievably prophetic. It is really so close to what I just spent the last 45, 50 minutes going through with you today.
On behalf of the Ontario Caregiver Organization and all the participants today, we would like to extend a big thank you.